Hello, my name is Victoria Boardman. I'm part of a team from Leeds Teaching Hospitals. We recently performed a service evaluation of pre-operative coagulation screening in our neurosurgical patients. Pictures are from RHS Garden Harlow Car in Harrogate near Leeds. Guidelines from the National Institute for Health and Care Excellence recommend against routine pre-operative coagulation screening. This is supported by evidence from the British Committee for Standards in Haematology and others that blood tests are less predictive of bleeding complications than structured history taking. Neurosurgical populations are excluded from this guidance, and coagulation testing is common in this group because of the large impact a small volume bleed can have. We aimed to determine whether the tests we performed in our patients led to any alteration in their management. Coagulation tests involve a significant cost, and abnormal results can lead to additional tests and delays to surgery. Our patient-level information and costing system team compiled data for all patients undergoing elective or emergency neurosurgery in 2019. We reviewed the records of all patients who had abnormal results in the 6 months before surgery. Of the 1,124 patients who had a neurosurgical procedure during this period, 20 patients had an abnormal initial coagulation screen once we excluded those on anticoagulant medication. In most patients, no significant new diagnosis was made. Only 2 patients had their management altered due to an unexpectedly abnormal result. One patient had a partial factor XI deficiency. She had no bleeding history despite previous surgery, but given that she was having a major intracranial operation, it was decided to treat her with preoperative octoplas. The second patient was having emergency surgery and was in the high dependency unit with other organ failure. His abnormal coagulation was most likely due to new liver dysfunction, and he was treated with vitamin K and fresh frozen plasma. We felt that although the yield from preoperative testing was very small, it remains significant, and we feel that we should continue our current practice of testing coagulation preoperatively. However, we found areas where our preoperative screening process could be more efficient. 603 of our patients had more than one normal coagulation screen performed in the 6 months before surgery, which represents waste. We found that follow-up of abnormal initial tests varied significantly, with different tests being performed and lack of consistency in referring to haematology. Further testing resulted in delay to 2 operations. We plan to reduce waste in our service by not repeating normal results unnecessarily and by introducing guidance for the follow-up of abnormal results. This will require educational interventions for staff, after which we will evaluate our service again.